I'm going to hand over to you, Mo. Perhaps you could tell us a bit about your career and your role at Mount Vernon, and then we're going to share slides.
Lovely. Yeah. So I am currently at Mount Vernon, actually doing a research fellow post in clinical oncology with Professor Hoskin, looking specifically at cervix cancer. But I've essentially completed my clinical oncology training, and I'm due to probably CCT and pick up my consultant post towards the end of this year. And yeah, no, I'm quite excited to talk to you today about immunotherapy, because I can imagine with how things have been going over the last 2 to 3 years, it's not just the names of the drugs, but the indications and where they're being used now. It's exploding, isn't it? So if you're happy, I can start sharing the slides, and I can crack on and do that.
That's great, thank you. And do put any questions in the chat box, and we should have 10 minutes or so at the end for questions.
Perfect, thank you. So hopefully you guys can see the slides. So what I was going to say was I might not see the chat box, so you might have to prompt me if anyone's asking a question, but please feel free to interrupt or ask a question if something sort of doesn't make sense. It is going to be slightly interactive at points, and hopefully there'll be a discussion at the end, and I'll try and get some time for that as well. But let's get started. So the whole point of this talk really, and I'm trying my best to make it as accessible as possible for you guys in the community, whether it's GPs or those in hospices or in the community palliative care teams, is the first bit is going to be about just what is it? What is the immunotherapy? How does it work? Why do we use it? Why does it work in cancer? But also looking at the different indications it's starting to be used in. You know, a few years ago, it was only being used in very few cancers, and now you almost see that it's being used almost everywhere. And then the second half of the talk is probably dedicated to the peskiest aspect of immunotherapy, which is the toxicity, and how actually overwhelmingly that may or may not show up in not just our practice, but in your practice in the community, whether it's a GP service or in the hospice or in the patient's own home when you're asked to see them. So let's just start off with some basic cell biology from a cancer point of view. We were traditionally trained from a cancer point that there were 6 hallmarks of cancer. And you can see that's the top picture here. Essentially, cancers would evade growth suppression. They would, invade and metastasize. They would replicate and become immortal. They would induce new vasculature, and they would resist cell death. And they would also sustain proliferative signaling. So what that means essentially is you have this perfect storm of undying, cells that had unrestricted potential for proliferation, growth, and metabolism. And further complicated by just instability in genetics. So, you get lots of mutations which force even further characteristics for the tumors to grow and metastasize, but also vascular induction and invasion. But what's happened since 2000, the year 2000, which is where we have the 6 hallmarks of cancer up here, is there's been an explosion in our understanding of how complicated the cancer biology is. And the thing that we're going to talk about today is this bit here, which is the avoidance of immune destruction. So this is the immune evasion here, which has been increasingly recognized as a really important factor in cancerogenesis and the development of cancer, but also why cancer happens in the first place and why people respond in different ways. So what I mean by immune evasion is if you look at point A right on the left here, that's what you traditionally expect your tumor cell to interact with your cytotoxic T cell. So that's the CD8 positive T cell. A cytotoxic T cell is one that essentially negotiates with the tumor, recognizes there's a tumor, and actively either kills it or starts a cascade of cytokines, which leads to the death of the tumor. Now, what happens in cancer is there are multiple mechanisms. So the big one is, first of all, the cancer stops being recognized by the immune system. It changes the receptors on its shell. And so that the immune system stops recognizing it for whatever reason. Point C here, which is the one I want you to focus on, which will be a big part of what we are talking about today, is actually the tumor directly interacts with the immune cells and tells them to stop working. Okay, and that's what you can see here with this yellow and red ligand receptor interaction. Okay, and then finally, the actual environment around the tumor itself is absolutely terrible for the immune system. It's usually hypoxic, which means cells can barely make it in there. it's usually full of other cells like regulatory T cells, which actually like to stamp down on immunity. And so therefore you have this environment in cancer where the cells aren't expressing the right receptors. The tumor is telling the immune system to go away. And at the same time, the immune system is really struggling to become active in that environment. So when we talk about immunotherapy in cancer, there's these families of treatments. Okay, so the most common are your checkpoint inhibitors. Okay, these are the ones that we are going to talk about today. And I'm going to go through them in a bit more detail. They're called checkpoint inhibitors is because these checkpoints are used by cells naturally to slow down growth, to sort of calm down the system. And the cancers essentially hack this system so that they can proliferate, grow, and avoid the immune system. Cell therapy is what's most commonly used in hematology. So if you've ever heard of CAR T therapy, long story short, they harvest your own immune system, they genetically modify it so that it recognizes the cancer, put it back inside you, and then re-inject it, and then therefore it fights the cancer off. Cytokines, very old-fashioned treatment. We don't really use it that often, but for those who remember, we used to use interleukin-2 for renal cancers and melanomas back in the day. Very aggressive treatment, very toxic treatment. That forces the immune system to wake up. And otherwise now there's a growing movement of using vaccines in cancer, such as dendritic cell vaccines, which again stimulate the immune system to wake up. And finally, right at the bottom, mostly used in melanoma is viral therapy. You're basically hijacking the cellular system by injecting a virus that introduces different epitopes so that it can be recognized by the immune system. But we're going to focus on the first point because this is actually the most common one you're going to come across and the one that has the most impact on your practice. So checkpoint inhibition. These are, as Roz was saying earlier, the names are very difficult to pronounce. But what you'll notice from this slide, the way they work is exactly what I mentioned before, which was the mechanism C here, which is you've got the tumors essentially driving the immune system of energy, so low energy, low activity. And it does this through various receptors and ligands. Now, this is the majority. There's one more on this list that isn't there. It's called dastirolumab, but don't worry, it's also a PD-1 inhibitor. But you can see that the majority of these receptors have been investigated and tried in PD-1 or PD-L1. PD-1 is what's called programmed death. It's found on the surface of the white cells, and PD-L1 is this yellow thing here, which is found on the surface of the tumor. And essentially, when they interact, the T cell goes to sleep. It doesn't do its job. Okay. So tumors that are high in this ligand, or if there's a lot of this ligand available, you'd say, well, actually, isn't that a good target? Why, if we can stop that, then maybe we can awaken the immune system, and therefore we can get the immune system to recognize the cancer is there. And that's exactly how checkpoint inhibition works. CTLA-4 is another receptor. Ipilimumab is one of the oldest immunotherapies we have that are checkpoint inhibitors, and it works in a very similar way. So this is a very busy slide, but I want you to focus on specific points here. But these are essentially the indications for immunotherapy at the moment, and they are still growing. Okay, believe it or not, there are still indications missing from this slide. But the reason I'm showing it to you is because no wonder you are seeing so much of it in the palliative care setting, because it is used for virtually every indication. There are radical indications for it. What I mean by that is it's used in the adjuvant setting. But mostly, if you look at this slide, you can see that there's the words 2L and 1L. That means first line, second line. That's mostly in the palliative setting when it's saying that. Overwhelmingly, checkpoint inhibitors are used in metastatic disease or incurable disease. There are some adjuvant indications, such as, for example, adjuvant ipilimumab, nivolumab, pembrolizumab in melanoma, or adjuvant treatment in lung cancer, or neoadjuvant treatment in lung cancer. But the majority you can see are in second line, first line, or third line treatments in solid cancers. Okay. And they are all different agents, although they work on the same receptors. It's all as a result of the different clinical trials that have come out showing the survival benefit, allegedly, from these checkpoint inhibitors in these tumors. Okay, but what you can see is it's virtually every organ type now has some form of immunotherapy tagged onto it, whether it's in the first, second, or third line. And I thought I'd show you this because what you'll notice is that some cancers are more likely to respond to immunotherapy than others. And you can ask, why is that? Why is it that, for example, sarcoma or breast, or even prostate have had very little in terms of immunotherapy, but actually your melanomas, your lung cancers, have had really good responses to immunotherapy. And it's actually down to tumor heterogeneity. So if you remember what I told you, cancers are a mess with cell repair. They will get lots of mutations, lots of mistakes. And as a result, you get lots of different clones of the cancer. If you were to biopsy different parts of the cancer, you will have different receptors, different profiles. And what that means is that you're more likely as an immune system to recognize there is a problem if you've got lots of different cancer cells to look at. If they are all the same, the immune system, if it's not recognized it the first time around, is not going to recognize it the second time around. It's the same bland tumor. But if you force it to look at lots of different cancer cells, it'll probably pick one of them up and then start fighting the cancer. And so if you look, melanoma, which is right here on the right, this is the x-axis on here is the tumors. The y-axis is how many mutations you have. So if you look, the ones with the highest mutations are things like the melanoma and lung cancer and bladder cancer here on the right. And so it's no surprise they have the most immunotherapy at the moment. And you go all the way down here, sarcoma, thyroid, leukemia, carcinoid, things like that. These immunotherapy does not work in them for that reason. And examples that you may come across, okay? So remember I said that it's mostly in the palliative setting that you're going to have your immunotherapy, but it's not always the case. And even when it's in the palliative setting, do not assume that this is sort of a poor prognosis situation. So melanoma is a good example of this. You can have it in the adjuvant setting. So that's a curative setting where you have pembrolizumab for up to a year, okay, after you have your surgery. And then in the palliative setting, you can have really quite aggressive treatments. So combination of ipilimumab and nivolumab for 4 cycles, followed by single agent treatment up to 2 years after you finish, okay? And the reason why we know it works is the overall survival for melanoma. Those of us who remember, metastatic melanoma was a brutal diagnosis. You would die within a short amount of time. Chemotherapy did not work. And overall survival for melanoma has been transformed to multiple years, in fact, with some patients actually having a complete response. So the complete response in some trials, it can be up to 30% for some patients. So there is a good argument for looking at actually, because not you guys in the hospice are much better than the medics at the general hospitals are. But when the medics look at the word, palliative or metastatic, they immediately assume a prognosis of less than 3 months is what I find. There are situations like this where actually that's not necessarily the case. And similarly with lung, you get adjuvant treatments with durvalumab, adjuvant pembrolizumab. And then in the palliative setting as well, where you have triple therapy, they've combined pembrolizumab with chemotherapy. I just thought I'd add this one because I just wanted to show you how powerful this can be. So in mismatch repair deficient colorectal cancer, so this is a population of people with colorectal cancer who have a mismatch repair. It means that they are not repairing their DNA properly. So they have lots of mistakes in their DNA, therefore very heterogeneous tumors. They gave them this dostarlimab, which is a new immunotherapy drug, and they had a complete response on surgical specimen in 16 out of 18 patients. So very impressive for an initial trial. So it's not out yet, but it's very likely that this will become standard of care. An example I don't particularly agree with, that I think is a symptom of big pharma just trying to drive immunotherapy down our throats, is something like here in mesothelioma, where already a very poor overall survival, we're talking sort of 18 months at most with standard of care, 15 months, a slight improvement of 3 months with combination ipilimumab and nivolumab, but this is now NICE approved as first-line treatment for mesothelioma. And you can imagine my fright at seeing frail mesothelioma patients on combination checkpoint inhibitors. I'm quite frightened by it, actually. But this is the point. We do it because if you look at the yellow line and the blue lines on this graph, this is basically an extrapolation of a Kaplan-Meier graph. So what this graph is showing you is survival over time. So the x-axis is have you survived since the treatment? The percentages are always on the y-axis, but the x-axis is the time. And what you can see is with traditional treatments, which are these ones down here, chemotherapy, targeted therapy, etc., patients die and it hits the x-axis. But with the immunotherapies, you can see, look, it plateaus. It just continues going forever at one point. And that's because there is a significant subset of patients, 10 to 20% of them, that have a complete response and they stay alive. We don't know who those patients are when we start treatment. We have no idea. And we have no idea really how to figure that out either. But that's the special thing about immunotherapy. It's this plateau. But at what cost does this all come? These drugs are really expensive, right? So nivolumab's been around for much longer than maybe a few of the others. So it's actually cheaper than maybe a few of the others. But we're looking at these sort of figures when you're giving it up to 2 years. You can argue you're compensating for the morbidity that's associated with metastatic disease and the dying, and therefore it's cheaper to do this. But you know, if you have hundreds of patients on this treatment, it's fairly expensive. But also the institutionalization. You've got patients who are maybe dying, and you're putting them on these treatments, and they're coming to clinic, they're having their infusion, they're having their blood tests. But more importantly, the last point, which is what I'm going to spend the rest of the session talking about, which is actually the toxicity. And this is the point I really want to drill in. So the toxicity of the treatments is fairly a heavy burden. And because we have an increase in the indications of giving immunotherapy, you guys are going to see so much more of a fallout as a result of what we are doing in the clinic. So this is a very busy slide, but I don't want you to read all the small print. I just want you to appreciate what can happen with these treatments. Essentially what happens with immunotherapy, it's a double-edged sword, because what you've done is you've activated the immune system. That's great. That's wonderful. And it will target the cancer likely. But there is a lot of collateral damage. The immune system now is hyperactive, and it will at some point recognize your own tissues as enemy as well. And as a result, you get immune invasion and immune toxicity to virtually any surface within your body. Some are more likely to be affected than others, but it truly is any body system. Okay, and it's always an inflammatory response. That's how it produces itself. And I've put the big ones that we see on the left. So erythema, which can be quite terrifying. You've got patients who will have whole body erythema, bright red, which, if not treated quick enough, can actually progress to Stevens-Johnson syndrome or toxic epidermal necrolysis. And I've seen that. I've seen 2 patients who have had, life-threatening toxicity secondary to immunotherapy. Thyroiditis is very common. Now, thyroiditis is the one that I don't think anyone minds patients having, because it's short-lived, self-limiting. And what happens is the patients become hyperthyroid. We don't treat them. We don't give them anything, because very soon after, a week or 2, they become hypothyroid. They've burnt their thyroid out. And then we just give them levothyroxine. So that's the one I worry the least about. But the last 3 are also fairly common, and I'll give you some numbers in a second. But they are the ones that can potentially be either life-threatening or life-changing. The consequences of severe colitis, hepatitis, or pneumonitis are huge, and we'll go through that in a moment. And the sad thing is, that plateau I was talking about. The same way you get a plateau with survival, you also get a plateau with toxicity. So the same mechanism that gives you the tumor response gives you the toxicity, and you're also going to likely have a plateau of toxicity. And that's the scary thing here. And you can see that, first of all, the first point I want to make is when you have immune toxicity, okay, and you've got colitis or pneumonitis or nephritis or whatever, it usually means that your immune system is awake, and therefore the chances are it's actually fighting the cancer. And we can see that with these figures. Nearly 70% of patients who had to stop combination immunotherapy achieved a complete or partial response. So even though they stopped their treatment because they had toxicity, they actually had a really good response to their cancer. Okay, it just means that the immune system has gone haywire and is attacking everything. And if you look at the graph down below, okay, you can see that actually for some of them, like the rash, hepatitis is notoriously slow at improving. Look, it takes such a long time to recover, and it's still not completely recovered. Same with pneumonitis. The thyroid is exactly like I said, it's sort of self-limiting, it's very quick. And this is a problem because you might stop the immunotherapy, but the damage is already done. So what will happen is patient has progressive disease with immunotherapy, or for example, they've got a serious immune toxicity. And then we say, oh gosh, they're really frail. That's it, end of life care, discharge to hospice for respite or for end of life care. And that's it. We won't really, get that engaged with them anymore because, well, we're no longer treating them. But these patients are still within the window of sustaining immune toxicities, which is why it's important that you're familiar with the actual mechanism and why this happens. Because even if a patient has stopped their immunotherapy, if you look at this graph on the left, there is still this window of many weeks and months where they are technically at risk of developing these things. And the risk is actually highest if you have combination therapy. The risk is obviously highest if you are having the immunotherapy actively or very soon within the window of having it. but technically they can happen at any point in the patient's timeline, but obviously less the longer the time is without the treatment. So these numbers are a bit sobering, right? So in the first trials with ipilimumab, 90% of patients had some form of adverse event. Now, the majority are not going to be grade 3 and 4. They're going to be grade 1 and 2. So self-limiting, easy to manage toxicities, okay? And if you look at pembrolizumab in lung cancer, it's not that common to get the severe toxicity. So 1 in 10 will have a grade 3 or a grade 4 toxicity, and actually better tolerated than chemotherapy in lung cancer. And only 1 in 20 had to stop because of immunotherapy-related toxicity. But bear in mind, that is a single-agent regimen. With the combination regimen, which is the ipilimumab and the nivolumab, you see that in melanoma, kidney, and now in mesothelioma. It is rare that the patient completes all 4 cycles. They always, by cycle 3, at least 75%, I would say, will have some form of toxicity, which stops them completing the 4th cycle. So combination therapy really is the big one. So how do you look after these patients? Now, the way I like to split it in my head for your purposes is if they're having active immunotherapy, they are going to be under an oncologist very frequently. Okay, we will be seeing them before every infusion or before every other infusion. They will be having regular blood tests before every infusion. We will be fully aware of them. Okay, and the way it works is when they come to clinic, we take a history. Any problems with your bowels, any problems with your lungs, any problems with your skin, anything new that you've noticed, are you tired, etc. We do an immunotherapy panel of blood tests. What I mean by an immunotherapy panel, if that's what we ask you guys to perform, if you call us or whatever, is basically a full set of blood tests, so bone profile, full blood count using these LFTs, TFTs, but also cortisol and glucose. Okay? And I'll come to why that is in a moment. And actually, the best place for these patients, if you're suspecting immune toxicity, is if they're under our care, is just get us to deal with it, or at least advise you from afar, because we have the infrastructure to deal with it quickly, especially if it's severe. It can be very difficult to manage these patients, and they will need multidisciplinary inputs and multiple specialty input as well. So if you ever want to look this up yourself, just Google ESMO immunotherapy guidelines, and this comes up. And it's only just been updated very recently. The older guidelines were from 2017, I think. Very good flowcharts, which I'm going to go through. You don't need to memorize them or anything like that, but it basically gives you a guideline. How do you assess the grade? Once you've assessed the grade, which is by the CTCAE criteria, so you look at the grade, you say, okay, this is the grade of the toxicity. What do I do? And it gives you a flowchart of how to treat the patient. So it's really good. Okay. But ultimately, all of this, the way you treat immune toxicities is some form of steroid intervention. That's what this is going to be. It's all about the steroids. So back to this, okay? Multiple system disease. Patients are going to present with a variety of symptoms, which will unfortunately overlap with their cancer presentation. So it's really difficult to sometimes differentiate between immune toxicity and cancer progression, for example, or infection. But if you look, there are some, red flags. New profuse diarrhea, you really do need to think about colitis. A new dramatic shortness of breath with, profound hypoxia, you do need to think about pneumonitis. Okay. Liver is very difficult to pick up because we tend to pick it up incidentally on blood tests, which is why we do them so frequently. But if the patient is jaundiced, that is definitely high up on the list, in addition, obviously, to metastasis. And then there are the rarer ones that we look at. You can get immunotherapy-mediated cardiomyopathy and cardiomyocarditis. You can get immunotherapy-mediated joint problems or arthritis. You can get inflammation of the pituitary gland, which completely shuts down your adrenal axis. And therefore, you can go into an Addisonian crisis, which means that you drop your blood pressure and become very, very unwell. So it can affect any system. So the differential has to be really quite wide. But by having a wide panel of blood tests, you are able to sort of rule out any of the sinister ones quite quickly, and then maybe focus on the more likely causes in your cases, which is the cancer probably causing those symptoms. So how do we manage the toxicities? So early assessment is key. If you suspect it, if you have strong or even strong evidence that this is an evolving immunotherapy toxicity, then exclude the non-immunotherapy causes, think of rarer toxicities, and then get the oncologists involved early, okay? Because what we will do is consult our algorithms, and then we will give advice about how to immunosuppress them, these patients, and then how to taper the steroids, which is another whole chapter in this whole saga about how we deal with steroids and high-dose steroids. But essentially, as I said already, grade 1, grade 2, grade 3 and above, but largely speaking, grade 1 and grade 2, which is the most common, okay? That can be self-limiting and managed as an outpatient, but it's your grade 3s and aboves where you start to think, okay, this patient probably needs admission. They need IV treatment. So the best way to go through this is through some cases. So 42-year-old lady, metastatic melanoma, and has received 3 cycles of combination immunotherapy, okay? And she's got contact with the AOS line because she's under active treatment. She can call them, and she's told them these symptoms. I have profuse diarrhea. I'm going 10 to 12 times a day. It's worst at night, and it's crampy. What do I do? So if anyone wants to volunteer, what am I alluding to here? What's the diagnosis? Likely.
Colitis.
Yes, colitis. Good. So, oh, I've just seen that on the chat. You've put the ESMO guidelines. Thank you. So yeah, colitis, right? So this is what the algorithms look on the ESMO guidelines, okay? All of us oncologists use them. I think every trust has their own, but to be honest, they're all derivatives of this. So I don't want you to read the small print. The whole point is you're looking at grade 3, which is an increase of 7 stools or above. She's already well beyond that, okay? And that's when you start to think, okay, she's probably got immune colitis. This doesn't sound like an infection. What do we do? Well, you give them IV methylprednisolone, high dose. We're talking at least 1 milligram per kilogram. In our trust, we give 2 milligram per kilogram. These are huge doses of steroids, okay? We might do a CT scan because that can delineate other causes. For example, you might have an infective colitis, or gastroenteritis, which might be a bit more visible on scans. But ultimately, what they'll need is also a biopsy because you can get microscopic colitis, which manifests like this, and it won't manifest on a scan. And what I want to sort of take your attention to is this is how serious it can be. If you look at this bottom paragraph, if you can read, it's quite difficult to read, is you might actually have to have infliximab, which is a monoclonal antibody TNF alpha inhibitor, which can be used to reduce the inflammation of the bowel. But ultimately, if there's no response, you might even have to have a colectomy because you're treating this almost like an old-fashioned ulcerative colitis patient. It's almost like a pan-proctocolectomy that you'll need to have. And it's pretty frightening if that's what needs to happen. But if you deal with things early, colitis does respond to steroids quite quickly. The next case, so this is a gentleman who's had adjuvant treatment, okay? So this is a man who's technically had curative surgery, and this is precautionary, the pembrolizumab we're giving. We're giving the pembrolizumab to reduce the risk of recurrence. And he gets this pembrolizumab. We used to give it every 3 weeks. Now we give it every 6 weeks, thankfully. So he comes before his 7th cycle with these blood tests, and he's completely asymptomatic. Does anyone want to comment on what the likely diagnosis is?
Hepatitis?
Yes. So it's classic hepatitis or immunotherapy mediated hepatitis. What you have is the transaminases. If you do the AST as well, that will be sky high, will be very high compared to the previous reading, and it will jump in the hundreds within short days. But the bilirubin and ALP don't tend to go as high. They can do, but that tends to be a later sign. We haven't done, for example, the AST for this gentleman or their GGT, which is the other enzyme that we can do in this context. But also their clotting is important because that's another element of liver function. But you're right, this is hepatitis. And this one is really difficult to treat because remember that graph I showed you? It's got a very shallow, it just takes ages to get better. And it all depends on the ALT or AST number. And that's what sort of guides how you treat these patients, okay? And again, it's IV methylpred, 2 milligrams per kilogram up to sometimes that we have to give, but you have to rule out other problems. You know, is this because of viral hepatitis? Is this because of something else? Do we do a liver scan? Do we do a liver biopsy? And these patients can sometimes be on high-dose steroids for months, with an ALT improving by 10s or 20s every week. It really is horrendous for them. So this poor gentleman, you can recall, is only having this adjuvantly, and then all of a sudden we give him, autoimmune hepatitis, and he has to take high-dose steroids for months. And this does happen. Whoever finds out, whoever gets the toxicities will win a Nobel Prize. I guarantee it, because for me, it's extremely disheartening when this happens. And this is it. This is a whole new chapter in immunotherapy treatments, because now we have a whole class of patients, and I'm sure you've met them, on high-dose steroids. And, they start off at 1 to 2 milligrams per kilogram of IV methylprednisolone, all right? And that's, for your average patient, approximately 100 milligrams of methylpred, which is equivalent to 100 milligrams of prednisolone once a day. 100 milligrams of prednisolone once a day, which they will be taking for many days in a row, and only stepping down probably on average 10 milligrams every 7 to 10 days. Okay. That means they are probably on these high doses for months. Okay. The reason why we have to wean slowly, some immunotherapy toxicities you can wean quicker. Okay. But things like hepatitis, no, that takes ages. Things like colitis, no, that takes a while. And you have to be slow, because if you wean too quickly, the immune system is just going to wake up again. Okay. And the term I like to use is immuno-arresting doses. This is something I've made up. But the whole point is you're essentially completely arresting the immune system by doing this. And as soon as you drop, let's say you go down to like 40 milligrams of prednisolone, it's classic. The patient will call you the week after, oh, my colitis is back. You re-escalate them to 50 where they were fine, and then it subsides again. But then what do? You're kind of stuck, aren't you? And that's the kind of stuff that we have to deal with in clinic. And it's not without its consequences. And I really feel that this is an area that is not been managed very well. And I feel that it requires a lot more guidance. And I think there are guidelines internationally, but not formally. And it really bothers me, because steroids, as you know, can cause diabetes. Pretty difficult to control diabetes as well. Muscle wasting, the patients become weaker. They stay in bed. They stay in the chair. They can't go upstairs. Their quads are completely atrophied. Insomnia, if they take their steroids sort of later in the day. Infection. We've just had a patient that we've had to transfer across to Watford General with cavitating pneumonia, very odd cavitating pneumonia, because he's been on steroids for more than 4 months. It must be something weird, like a Klebsiella or a staph, I'm sure. Something that you only get if you're a bit immunosuppressed. Thrush is very common. Osteoporosis. We thin these patients' bones with these long-term steroids. We really should be thinking about the bisphosphonates in these patients. And not to mention the GI tract. Okay, they all can ulcerate or perforate with long-term steroids. And then the ones at the bottom, it depends on the dose of the steroids, etc. But you can get psychotic with steroids, and you can get cataracts with long-term steroid usage. And the last one I've put is one that we neglect. So once we've managed to wean down patients after 4, 5, 6 months of high-dose steroids, their adrenal axis, so their adrenal gland and their pituitary gland, has just forgotten what cortisol is. It's forgotten what this hormone is, and it stops producing it. And therefore you stop producing your own steroids, because it's been such a long time. You've suppressed it with all the hormone, the steroids you've given. So then you have to replace it yourself long term, and the patient stays on 3 to 5 milligrams of prednisolone a day. But the ultimate consequence of high-dose steroids is you undo a lot of the benefit that you did initially. All that immune activity that you did to basically, hit the cancer is now nullified if you stay on high-dose steroids. There's a chance it'll resurge when you bring down the steroids, but you can't give immunotherapy on high-dose steroids, and it won't work, the previous stuff that you've done. So techniques that we have to sort of counter that include steroid sparing. So we use mycophenolate, for example, or infliximab, or tacrolimus, or cyclosporin. These are other immunosuppressive agents that we can use to maybe lower the steroids, and then maybe introduce them so we can lower the steroids even further. And so you'll find some of our patients on these agents when we are really struggling to wean down the steroids. And then, believe it or not, despite all this horror show of immune toxicity, some patients do restart their immune It's all down to how quickly they wean down off their steroids, how bad the toxicity was to begin with. Some immune toxicities are easier to pick up and easier to treat, as you can see from this table, and some of them are much harder, more life-threatening, and very difficult to deal with. And so that's what sort of mediates how we make decisions about restarting. But a grade 3-4 toxicity, it's highly unlikely you will restart your immunotherapy because that can be life-threatening. So this comes to what we do in the community for you guys, whether it's GPs or palliative care physicians in the hospice or community or patients in the home. The vast majority of patients, if they're on immunotherapy, that safety net of the cancer unit and the acute oncology unit exists, okay? You will always have that safety net. And I'm going to talk to you about sort of who you can speak to in that context. But as I've already mentioned, there are subsets of patients, and I'm going to tell you who they are in a moment, that you will still see. Patients will still turn up to their GPs and say, oh, I'm on immunotherapy and I have this symptom, for example. Or they'll be recently stopped with their immunotherapy, or they're currently having immunotherapy and they're in a hospice for respite or at home recovering from something. And then you will see them as a community nurse. It's difficult to sort of know what to do with these patients because one, if you make a decision, is that going to interfere with the immunotherapy? But two, am I missing something? Is this an immunotherapy problem and I'm just thinking it's something else? And I think that's really difficult for you guys to manage if you're not used to seeing these on a regular basis. But two things I thought I would highlight to you, which I call peculiarities, are worth mentioning. So if you speak to most of the medical oncology colleagues that I work with, they have a slight mini obsession with antibiotic usage in the context of immunotherapy. And what I mean by that is there's a growing body of evidence that your immune response is significantly modulated by your gut microbiome. And there's a lot of evidence that actually if you use a lot of antibiotics, your response to cancer treatments in general, but also your response to immunotherapy is significantly worse. And that's because you actually remove the heterogeneity of your gut microbiome by blitzing it with antibiotics. Now, obviously, if the patient has an infection, they need to have antibiotics. But we're talking about, someone with a cough, which isn't worrying, that you think is viral. These people should not be having antibiotics, for example, because it will directly affect patient outcomes. And the other one, which is, again, I'm not so myself taken by this, but a few of my colleagues are, is if you have gastroesophageal reflux or dyspepsia, and we give lansoprazole quite frequently to our patients, and it works really well, and I like it. But apparently that also mediates the gut microbiome and can influence immunotherapy responses. So we quite liberally prescribe famotidine here, and even cimetidine, which is a really old rusty drug. We used to have ranitidine, but we can't use that anymore. I'm less worried about this second one, but the first one, it's that they're very, very picky about it, the bosses, about antibiotic usage. And they'd most certainly like to know about something before anyone starts the antibiotics. But for your purposes, really, this is the categories I was talking about. You're only really going to end up, the point I'm trying to make, is if the patient is no longer under our care, the two families of patients you're going to be dealing with are patients who have completed treatment and we've discharged them for routine follow-up. So someone that we've completed adjuvant immunotherapy for, he's done really well. Thank you very much. We'll see you in 3 months' time. That's someone who can most likely be seen in the community by either you guys or by GPs or anyone there. Or palliative patients who have completed immunotherapy or the immunotherapy was stopped either because of immune toxicity or because of disease progression. And the patient's really unwell and they're no longer fit for any further treatment and they're sent home, discharged from our care for community palliative care or for hospice. And those are the patients that you will be seeing. And actually, that's the population of patients that may or may not be on high-dose steroids if they've essentially had an immune toxicity. So how do you approach them? So everything in red on this slide is the thing that basically makes it more likely an immunotherapy toxicity. So if you tick all of these boxes, you need to start thinking, okay, is the problem I'm dealing with related to immunotherapy? So if you're currently on immunotherapy, your risk of immunotherapy toxicity is much higher than if you'd completed it a while ago. If your last dose was recent, again, your risk of toxicity is much higher than if you completed it many months ago. If you had a previous immune toxicity, chances are your risk of having it again is quite high. And if you're currently on steroids, okay, and all of a sudden you've weaned those steroids and then some toxicity emerges, is that because you weaned prematurely? Those are the questions you need to ask when you approach the patients. And then, in your mind, you're going to have this debate. Is this an immunotherapy problem that I'm seeing my patient for? Or is it a non-immunotherapy problem? Most of the time, look, it's going to be non-immunotherapy related. Okay, they are going to have a very, the cancer in its own right is a high competing factor for any sort of toxicity. And we'll see that in a second when we look at the final two cases. But my point is, if you suspect an immunotherapy toxicity, obviously the context of why you are seeing the patient matters, but consider speaking to us early. And the reason why is because, one, there's a lot of things that we can do that you can't easily do in the community, such as bloods or imaging or endoscopy, or even just the monitoring. But two, I do think that some of these quite dangerous presentations, or even the mild ones, if managed correctly, can improve symptoms. So, if you've got a grade 1 or grade 2 presentation, like you've got an itchy rash secondary to immunotherapy, fine, yeah, you can call us or you can figure it out yourself and give topical steroid and it'll work and it's great, not a problem. Okay. But if you have, so if you just look at the last point, it's worth discussing it with us anyway, because actually we might be interested to treat the patient if we're worried about them, if it is an immunotherapy toxicity. There might be times where you think actually it's not appropriate that the patient is referred back to the oncologist, or it's not appropriate that they're referred back to the hospital because their prognosis is really poor. But for example, you think they're developing a pneumonitis. Nobody will say, why did you do this if you started them on high-dose steroids of your own right, orally at least, yeah, in that sort of context. Because if someone has got pneumonitis in their final days, that's miserable. If you give them high-dose steroids and their breathing improves, then you've done them a massive favor. And if you feel like actually, transferring them to hospital in order for them to get better symptoms, in order for them to come back to the hospice is something that you do, we would be more than happy to consider it. And it's worth looking at the tools that you have available to you in the community that you guys should be able to use to your advantage, actually. So the patient has these resources, which is access to the acute oncology service, right? Which, as you know, is a 24-hour hotline where there'll be a chemo-trained nurse behind the line, sort of to give advice. But also the CNSs for the team. So, you've got a lung patient, they've been recently discharged, they've got what you think is a problem, you can call the CNS. Patient will have the details. I'm worried that this patient has an immunotherapy toxicity. What do I do? Okay. But ultimately for you guys, and this is what I really think you should use a bit more sort of power to, is you can always contact us through two ways. So sometimes I get letters from the GP sent as urgent. They get emailed to the secretaries and the secretaries immediately email them to me. I've got like my email on my phone. I look it up. I go, oh gosh, yeah, that's an interesting query. And it gets very quickly. I don't know about other specialties, but at least in oncology, I don't know what your experience is, but from my side, at least, I welcome referrals from the community, whether it's letter or email or whatever. Yeah, more than happy to see them. But ultimately, if you think it's something that needs more urgent advice, I've received calls from hospices many times as the oncology SPR, more than happy to advise by anybody, nurses, consultants, registrars, it doesn't matter, because at the end of the day, they are our patients just as much as they are yours, and we're more than happy to sort of advise if necessary. And that is 24/7 available for advice. And I think you use that to your advantage. If there's any sort of concern, even if it's something like, well, actually they're on this immunotherapy, you've never heard of it before, can I just ask you what it does and whether it is related to this symptom? More than happy to advise on that. So good. So I'm sort of wrapping up now. So 76-year-old lady with metastatic lung cancer. We've stopped the pembrolizumab because they've got progressive disease about a month ago and they're not on any treatment at present. So they're at home, and whether you're the GP or the community palliative nurse or the hospice team, you've been asked to see the patient at home because they've got increasingly short of breath. So what I want you to do, either in the chat or either to shout out, is just a list of differentials that you have availability, sort of like what are the differentials for this sort of presentation?
I guess if I didn't know that pneumonitis can start, with that plateau effect that you've explained, we would assume in palliative care that this was worsening lung cancer, infection, pleural effusion.
Good. So, I agree with you. I would still think that is the number one differential. But the whole point of this whole lecture, I think, is actually you just need to keep it at the back of your mind. Because actually, if you don't, for example, progression of disease with lung cancer, what would you expect? You'd expect either a lobar collapse to maybe to be causing the patient's symptoms, which you might be able to elicit on examination. You might sort of think they're producing a lot of sputum, for example, things like that. So that's, either the cancer or infection can cause that. But you're spot on. I think you have to keep the differential wide, but immunotherapy is right at the bottom. Okay, but it is there. It has to be there. And you're right. All these things due to the cancer. So what I tell people when I give talks about this sort of stuff is it's either the cancer or something that we have done or something else, and that's how you have to split it in your head. And with regards to the cancer, it could be metastasis, progression of disease, or collapse, or pericardial effusion, or pleural effusion. You can have a chest infection. But also, is this cardiac? Is this heart failure, for example, things like this? Or is it a massive PE? So PE is very common, as you know, in the cancer population. The thing about immunotherapy is it's widespread inflammation of the lungs. So the patient will very quickly, so over the course of days, have worsening breathing, which is, a dry cough is characteristic. But then again, you get that with lung cancer anyway. But also, shortness of breath on minimal exertion. So their hypoxia is very pronounced. It's almost like having, the classic one is PCP pneumonia. It's almost like that, or lung fibrosis, where you get this very predominantly type 1 respiratory failure like picture. And it's not improved really with positioning or anything. It's just really bad. So, no, it's not just the pneumonitis. You can get myocarditis and pericardial effusion secondary to immunotherapy. I've seen this, and that presents as shortness of breath. So it's really difficult, I think, in the community to sort of start considering this. To be fair, 95%, if not more, of your presentations are going to be the top few. Immunotherapy will be at the bottom of the list, but the whole point is you just have to, keep it at the back of your mind, because if you think actually this doesn't fit, the tumor is small, they don't have a lot of cancer in the lung. Why are they so short of breath? Is this something else? Is this a PE? Is this the immunotherapy? And again, showing you this sort of matrix all over again. We don't have to go through it, but the whole point is, you for grade 3, grade 4, you would admit, do a CT scan, maybe even bronchoalveolar lavage, IV methylprednisolone. These patients are really unwell. It's not, the ones that I've seen, it is life-threatening when they get pneumonitis. And finally, 65-year-old gentleman with metastatic bladder cancer, the atezo was stopped, after 1 year. So let's say it was stopped a few months ago due to immune colitis, and they're on weaning steroids. So they're currently on 20 milligrams of steroids, which was stepped down a week ago. They're in the hospice because they've had progressive disease, generalized deterioration. They've got a really short prognosis of a few weeks. And all of a sudden, they're just more confused. And they've got a urine dip, which is showing blood and protein, but no nitrites or leukocytes or anything like that. And they've got poor urine output. And their blood shows a creatinine of 400. Low sodium, high potassium. Again, if you can just put your differentials either in the chat or to shout them out.
Ureteric obstruction, inflammation of the kidneys.
Yeah, so nephritis.
Yep. Yeah, I guess those would be my two key ones.
I think you're right. So this is a bladder cancer. Ureteric obstruction is, or hydronephrosis, or bladder obstruction or retention is very high on that list. The blood in the urine dip and the protein might just be related to the cancer. Might not necessarily mean anything, but equally, blood and protein in the urine with a severe AKI could well be a nephritis or a new nephrotic picture. The electrolyte disturbances, again, could just be due to the renal syndrome, but also it's a bit of an odd pattern to have both of those in that sort of way. Is something else going on here? Is this patient, developing an Addisonian picture secondary to the immunotherapy? Things like that. So very difficult to sort of, again, pigeonhole these. But what's common is common. What I don't want you to do is to immediately jump to nephritis. Nephritis is rare. You have to think of the more common stuff, rule those out. But if you have, and for example, this isn't hydronephrosis, they've had scans last week and there is no obstruction and their cancer is small in their bladder, it's just that they have metastasis to their lungs, which is why they're unwell, then you really start thinking, what else is going on here? Why is this happening to the kidneys? What have I missed? And immunotherapy may well be on that list of differentials if you've sort of ruled out any other causes for a severe AKI. But remember, this patient, they're on steroids already. Their initial presentation was colitis. It wasn't nephritis. And it's been a fair few months since we stopped the immunotherapy. The chance of them actually having an immune toxicity is quite low. So I wouldn't necessarily jump to that in the first instance, but it's at the back of your mind is what I would say. So we don't need to go through that. I think this is the last slide, which is essentially what I want to say as a take-home message. Discuss with oncology. More than happy to chat. And if you think this is a likely immunotherapy toxicity, the earlier you get involved, the better, because the earlier you treat, the better the outcomes in general, and the better the symptoms. And even if the patient's not going to come into hospital, if you think this is immunotherapy related, just bump up the steroids, see if that makes a difference. And inpatient intervention can improve symptoms in severe presentations. So even in a poor prognosis context, it's worth thinking about, and we are open to helping you with that if you guys think that is appropriate. I think that's it. I've left my email address up there if you guys have any queries or any questions or anything after that. But I think I've just run over time a little bit.